Yeah. Welcome everybody to our November user meeting, and we will have a really exciting presenter this time. And I would be very happy to introduce you this time two new speakers. Not new in dry eye management, but definitely this year new speakers. Dr. Melike GEDAR from Turkey and Dr. Luca from Italy. So would be very happy to share with you and with us all the newest things in a dry eye management and dry eye treatment. And we'll be very happy that you will enjoy these presentations. And if you may have also chance on time to fulfill any new enters or questions, feel free and send us the questions. And after each presentation and at the end, we will answer this question as much as possible. So I will give a chance to this time Men's to start. So welcome, Luca. As you know, Luca VIGO is one of the leading doctors in Carone's clinics in Milan, Italy, and is a big, let's say, one of the leading doctors in dry eye management all the world. And I'm so happy to have you in our webinar, and would be happy that you will share with you the last findings, what you found in your practice. Please, Luca.
Thank you very much, Peter. Thank you for the invitation, Peter. Thank you, everybody. And I'm pleased to share my experience as regards dry eye, especially correlated, as you can see, with the anterior segment surgery. So now I'm going to start in a while. Very good. So yes, I talk about tear film and anterior segment surgery because I think that there is a strict correlation between dry eye and anterior segment surgery. And this is the reason why, I mean, the anterior segment surgery, I decided some years ago to be interested in this particular field of ophthalmology, that is the dry eye, because when I operated some patients, I had very good results in terms of refractive outcomes, but some patients complained for other symptoms. And so I decided to understand why they were complaining, and I saw that they had some dry eye problems, some dry eye issues. So that's the reason why I started be interested in this kind of particular part of ophthalmology, and since then I decided to be involved in treating dry eye patients. So why the tear film is so important? We know that the tear film protects the ocular surface, both cornea and conjunctiva, has an antiseptic role, an antiseptic effect against the virus, also coronavirus and butters, and also the tear film cleans the ocular surface and allows to have a transparent and regular surfaces, and especially corneas. On the other hand, if we have a very bad tear film, we may have recurrent inflammations or chronic inflammations. We have visual fluctuations. We have an increase in corneal sensitivity, and sometimes we have also very small or wide surface degenerations, and the patient may have mild but also severe symptoms in case of dry eye. Both in case of bad quality of tear film, that means meibomian gland dysfunction, and especially it is correlated to excessive evaporation, and in case of poor production, poor water production, that means lacrimal gland dysfunction, that means the hyposecretive dry eye, in both cases we have an increase in osmolarity. What is osmolarity? Osmolarity is the concentration of solutes in the tear film. And we know that is very important, a very important exam. This is the first exam that I usually do when I have to screen my dry eye patients. If we have a situation like the one you see in this slide, where we have, sorry that I cannot see, let me see the screen, let me see if it appears again, sorry for, I don't know, okay, let's see. Okay, if we have a tear film, like you can see here in this slide, a perfect tear film where you can see the three layers, the outer one that is the lipid layer, in the middle one that is the aqueous layer, and the inferior one, the inner one, that is the mucus layer, and you have the concentration of solutes in an equilibrium, so that is in equilibrium. We have a situation of the corneal surface. You can see the microvilli on the epithelium that are perfect, that are healthy microvilli, and so they can keep the water on the ocular surface. In case of hyperosmolarity, we can have a situation like this, where there is a cell death, that means cell apoptosis, and you have a destruction of the microvilli, and so you have a situation like this. This means that the patient is complaining, and is complaining because it has a surface, or ocular surface, that is damaged, that is not in healthy conditions. And so why it's so important to detect dry eye patient, to screen dry eye patient? Yes, because sometimes also in a symptomatic patient, we have to detect if the patient has tear film issues. We have to screen dry eye patient because we want to classify our dry eye patient, because we want to successfully treat our dry eye patients. And we know that we can suggest a specific therapy to a specific patient that suffers from a specific kind of dry eye disease. And this is very important to achieve better results and, of course, our patient satisfaction. And it is very important, especially in case of anterior segment surgery, because anytime we have to do a cataract surgery, we have to do a refractive surgery, we need to check our anterior segment, we need to check the cornea, the conjunctiva, we have to check the refraction, and we have to be very precise in detecting biometry and to detect all our cornea data. It is very important, especially in case we want to achieve a metropia and we want to use multifocals, especially in cataract patients. And this is very important, especially in patients that want to be operated and they don't have any kind of dry eye symptoms. Because in case of bad tear film, especially in asymptomatic patients, we may have important variables in acquiring pre-op data. And osmolarity is associated, is correlated to this wrong data that we can get in the pre-op examinations, because osmolarity sometimes leads to very important and significant changes in corneal epithelium. And these may induce error in refraction and also in acquiring keratometry and biometry data. And this is explained also in this beautiful study that was performed some years ago, showing how it's important to treat the patient these are LASIK patients. It's better to treat patient with normal osmolarity than patient with hyperosmolarity before surgery, because you can see that the results, both in terms of uncorrected and best corrected visual acuity, are much better in case of normal osmolarity than in case of elevated osmolarity. And this may be explained if we focus on the corneal epithelium. You can see here a patient with a normal corneal epithelium. You can see that usually the thickness of the corneal epithelium is approximately 50 microns. And in this case, you can see the patient with a normal, a standard corneal epithelium thickness, and this epithelium is homogeneous on the corneal surface. In case of hyperosmolarity, you may have a situation like this. If you look at all these images, you can see, like in this case, that this part, that is the red part, means that here the epithelium is thicker, and in the green part is thinner. And there is it is not homogeneous on the central part of the cornea where is the pupil. You can see here the pupil. And you cannot detect this if you do normal standard corneal examination. I mean, if you check the total pachymetry, if you check the refractive power or the instantaneous or the axial power of the cornea, or also if you check the posterior elevation of the cornea, you cannot detect these changes in the corneal epithelium. But these changes are really important if you want to get precise data as regards refraction, as regards keratometry or biometry. Another example, this is another patient with hyperosmolarity, and you can see that both eyes have a thicker epithelium in the central part, both eyes, and it is not homogeneous on the corneal surface. As well, you can see that also in this case, if we check the epithelium, you can see this irregularity on the corneal surface. But if you check the total pachymetry, if you check the refractive power, the instantaneous axial power, or the posterior elevation of the cornea, everything is fine. So we don't know if you are getting proper data or not. I mean, in terms of preoperative data. And I think it is very important if you want to get beautiful and very precise results. Another example, the same patient with bad epithelium on the corneal surface, but all the other data seem very good. And this is the patient before and after the treatment. You can see that before the treatment, we have some areas that are not perfect with a thicker epithelium, a thinner epithelium in the same area. And after the treatment, you have a very important, very beautiful homogeneous epithelium on the corneal surface. So I think that especially before cataract, in case of multifocal areoles, in case of refractive surgery, where it is mandatory to achieve a metropia and to get very, very precise results, it's very important to screen all our patients before getting the pre-op data, just because if the patient have some bad tear film, some dry eye issues, it's better to restore tear film, to reduce osmolarity. And this means to improve ocular surface integrity, improve, of course, symptoms if the patient has symptoms, but this is because we want better and more precise pre-op data, and this leads, of course, to better outcomes after the surgery. And what we can do? Yes, one of the possibilities that we can use to reduce osmolarity is the IRPL. So it is the pulsed light, it is the EI device. We published this paper that was published on the JOVE journal 2 years ago, showing how is effective the EI device in reducing osmolarity before, of course, after surgery, but in all cases with dry eye patient and hyperosmolarity. And these results are statistically significant. So I think that it is mandatory to do this before getting the pre-op data. But we know also that anterior segment surgery may induce a decrease in tear film quality or quantity. This because there are some neurological issues under this because of incisions, I mean, in case of cataract surgery, also the flap creation in case of LASIK, or the ablation of the ocular surface in case of PRK may induce a decrease in tear film quality or quantity, because there is a change also in corneal sensitivity that may lead to an altered blinking rate, and this may induce also a chronic inflammation, especially in case of older patients. So in these cases, I mean, in cases where you can start having a beautiful and standard and normal tear film, may be useful also to use EI, for instance, to treat the patient after the surgery in order to reduce the risk of a visual fluctuation that is very important, especially in case of multifocal IOLs, to reduce the risk of epithelial corneal degeneration, very small corneal degeneration, especially after LASIK or PRK, to reduce the risk of chronic inflammation, because you know that in all cases of bad tear film, we may have a chronic inflammation that may onset after the surgery, and may also we can reduce the need to use artificial tears after the surgery. So in my experience, probably you understood this, I prefer to treat before the surgery. And when I'm not able to let the patient wait for too long, I prefer to treat the patient in between the protocol, in between the 3 sessions of IRPL. And so I prefer to do the first one, the second session, and then in between the second and the third session, I do the surgery. But I prefer, if possible, to check the patient, to screen my patient. If there is something wrong as related to the tear film, I prefer to treat my patients, to call back my patient to get the pre-op data after the treatment, and then I do my surgeries when I know that the tear film now is stable and is perfect. And so in my routine basis, I usually treat the 70% of my patient I prefer to treat before surgery, 20% during the standard protocol in terms of course, EI treatment, and only 10% after the surgery. In conclusion, I think that the tear film plays an important role in all cases of anterior segment surgery, and I think to have shown you the reason why. It is better, I think, to prevent than to treat post-op dry eye issues or dry eye symptoms. I think that the EI is very effective in restoring good osmolarity and improving tear film quality. And in order to achieve better results, I prefer to screen, as regards the tear film, all my surgical patients, and if it's possible, to treat them before acquiring data and before doing surgeries. I thank you very much for your attention, and I'm here to answer your questions if you want. Okay?
All right. Thank you very much, Dr. VIGO. And it was a great presentation. I invite anyone who might have any questions to type in their questions in the Q&A or raise your hand. We already have actually one question from Deborah Jennings. She's asking, how high of osmolarity are you concerned with?
Okay, you know that the osmolarity level there are standard values that might be evaluated and might be concerned. You know that usually under 300 everything is fine, but not only not every time under 300. The other important issue is that the difference in between the two eyes must be under 8 millismol per liter. So that means that if you have 290 and 300, that means that there is something wrong, because the difference in between the two eyes is higher than 8 millismol per liter. That means that there is something unstable in terms of tear film. If we consider the total amount of value of osmolarity, I can say that over 310, 320 millismol per liter, that means that there is hyperosmolarity, and you have to decrease osmolarity before getting data or before doing surgery.
All right. Thank you, Dr. VIGO. As well, if you have any other questions directed to Dr. VIGO, I invite you to ask them. In the meantime, I'd also like to introduce this poll. You can answer if you have an EI or not. And anyone is invited to join the forum to share with us your own experience. If you have any brief mention you want to talk about. Before we also welcome Dr. GEDAR, who is also here with us from Istanbul, Turkey. All right, I'm also just waiting a bit in case anyone else has any questions for Dr. VIGO. All right, so let's start with Dr. Melike GEDAR. She's here with us from Istanbul, Turkey. She's an assistant professor in Bahçeşehir University, the Faculty of Medicine, and she's been teaching there in the ophthalmology department since 2014. Dr. GEDAR is currently a part-time consultant in the ophthalmic oculoplastic and orbital surgery department at Dünya Göz Eye Hospital. Welcome, Dr. GEDAR. You're going to be talking about blepharitis and the EI. And please go ahead.
Thank you. Thank you for your kind invitation. I'm so glad to be here among all EI users. I want to share my experiences for the treatment of acute blepharitis or blepharoconjunctivitis with intense regulated pulse light therapy. I have no financial interest. As you know, meibomian gland dysfunction refers to the functional abnormalities of the meibomian glands, such as chronic and diffuse terminal duct obstruction and qualitative or quantitative changes in the glandular secretion of the meibomian glands. Meibomian gland dysfunction causes more viscous meibum production than usual, and patients can experience severe inflammation and bacterial overgrowth. According to the staging of meibomian gland dysfunction, treatment plan can be proposed. Treatment modalities for meibomian gland dysfunction include eyelid hygiene, warm compresses, eyelid massage, eyelid scrubs, and omega-3 fatty acids, artificial tears, topical antibiotics, systemic antibiotics, and anti-inflammatory therapy. Comorbid conditions defined as plus disease may require concurrent management according to standard of care protocols. Blepharitis is one of the plus diseases. Blepharitis is the general term for the inflammation of the eyelids as a whole. Acute blepharitis affects the anterior eyelid with the most prominent changes centered on the meibomian glands. Acute blepharitis associated with secondary conjunctival and corneal involvement is defined as acute blepharoconjunctivitis. The diagnosis of acute blepharitis or acute blepharoconjunctivitis is based on the clinical signs and symptoms such as inflamed eyelids, anterior lid margin telangiectasia, accumulation of collarettes around the base of the cilia, recurrent episodes of chronic red eye, styes, meibomian cyst, and keratitis, and clinical signs and symptoms were graded as mild, moderate, or severe. Like meibomian gland dysfunction, treatment modalities for blepharitis include meibomian gland extraction and probing, topical steroids, topical antibiotics, and for severe cases, systemic antibiotics can be needed. And the treatment should commonly be applied for a long time, and so patient compliance is needed. And despite diverse treatment modalities, complete and long-term relief of the signs and symptoms could not be obtained. The recurrences within the follow-up period can be seen frequently and require repeating the treatment. Additionally, long-term antibiotic and steroid therapy bears the potential risk of serious side effects. In our study, sorry?
Dr. GEDAR, I'm sorry to interrupt you. Maybe we're having a bit of feedback maybe for your microphone. Is it possible to maybe higher the volume or something?
Can you hear?
Yes, much better. Thank you. Thank you for the interruption.
If you miss something, I can start from over there.
I think it was fine enough.
Okay.
Maybe just.
Okay. In our study, we evaluated the effects of a series of 3 bilateral IRPL treatment, which was applied in addition to the standard clinical treatments in patients with moderate to severe acute blepharitis or blepharoconjunctivitis patients. 22 eyes of 11 patients were enrolled in the study. 5 were women and 6 were men. Mean age was 50. The age range was 17 to 77 years, and multiple chalazion surgeries had been performed on 6 eyes of 3 patients more than a year before. And, sorry, just a minute, sorry. And 2 patients had seborrheic skin type. There was no diagnosis of skin disease or previous skin therapy in any of the patients. The results of clinical evaluations performed at baseline and 10 weeks after treatment. These were slit lamp examinations, symptom scores of compression of the eyelid grading system, ocular surface diseases index, and ocular surface staining with Oxford grading scale. By using ICP ocular surface analyzer, lipid layer thickness, non-invasive tear meniscus test, non-invasive breakup time measurement, and meibography were performed. Treatments performed at baseline, week 2 and week 6, adjusting the appropriate pulse intensity setting following the manufacturer's treatment protocol for EI device. And the patient applied warm compresses, eyelid massage, and lid hygiene with tea tree oil shampoo daily. And in addition to IRPL treatment, all patients received topical azithromycin and dexamethasone for 14 days. You know, the EI device is specifically configured periocular IPL therapy device. Pulse intensities were chosen based on the Fitzpatrick scale according to the manufacturer guidelines. At each treatment session, both eyes of the patient were closed with opaque safety goggles. 4 adjacent intense pulse light were administered to below the lower eyelid and 1 to the temple. And in follow-up period, we observed clinical improvement in a very short time. Patients' complaints were resolved with only additional topical therapy. OST scores was significantly improved at 10 weeks after serial IPL therapy compared to the baseline. Over half of the eyes OST score was higher than 12. Oxford grading scale didn't show any significant difference. However, percentage of eyes showing the absence of corneal and ocular surface staining increased from 18 to 57%. Non-invasive breakup time was prolonged, but this prolongation was not statistically significant. At 10 weeks, breakup time was more than 10 seconds in 9% of the eyes. The mean breakup time increased by 47%. There was an increase in the mean tear meniscus height scores that was not statistically significant. However, all of the eyes became the normal range and tear meniscus height increased by 22%. Lipid layer thickness significantly improved in all of eyes, although the mean meibomian gland expression score didn't significantly decrease. 68% of the eyes had clear oil secretion at the end of the study. Meibomian gland loss area significantly decreased in both upper eyelids and lower eyelids. And in 36% of the eyelids, meibomian gland loss area was completely disappeared at the end of the therapy. You know, the IPL therapy was accidentally found to treat the dry eye due to meibomian gland dysfunction during its use for the treatment of facial rosacea. It has been used an effective and well-tolerated treatment option for meibomian gland dysfunction. It utilizes non-coherent polychromatic light to the periocular skin. The light absorbed by chromophores, hemoglobin, melanin, and water in the skin transforms heat, causes thrombosis and ablation of superficial blood vessels, and so decreases the inflammation. Although the underlying mechanism of the effect of the IPL treatment is not clearly understood, we think that most prominent mechanism of action in our patients are Demodex follicular's coagulation and necrosis, and secondary decrease of the microbial load on islets. The non-invasive nature of the IPL device is favorable, but however, incorrect use of IPL device can cause devastating intraocular complications. We didn't observe any side effect in any of our patients. In our study, we observed clinical improvement in moderate to severe acute blepharitis and blepharoconjunctivitis patients after a series of IPL treatments combined with short-time medical therapy without any side effect. We also find that ocular surface indexes, meibomian gland functional indexes, meibomian gland morphological indexes were improved. The main limitation of our study were its retrospective single-arm design, small number of patients, concomitant drug treatments, and short follow-up time. This is the one of my the patients, but she's not included in the study. She had many chalazion surgeries and medical treatments since her first trimester of pregnancy. She admitted our clinic with multiple chalazions and acute blepharitis when she was breastfeeding. And at third session, the patient was hopeless and unhappy, and I said to her, don't worry, we could do the fourth session. And after a month, she was completely recovered. We didn't need an extra session, and she's still well after a year and continues only with lid hygiene. Thank you very much for your attention.
Thank you, Dr. GEDAR, for this great comprehensive presentation as well. And I invite everyone to ask Dr. GEDAR and Dr. VIGO right now any questions you might have. We're already getting in some more questions. Here we have a question for Dr. VIGO. So what other than osmolarity, what objective evidence do you use to track improvement with patients? And I also invite Dr. GEDAR to later also comment. Dr. Luca, I think you're on mute.
Okay, unmute. It's okay. I usually, of course, check osmolarity because, as I told you, this is the first exam that I usually do when I have to screen my dry eye patient. But not only, of course, osmolarity. I check all other important exams in terms of dry eye because I check the NIBUT, I check the mammography, I check the tear meniscus, I check all these exams. And then, of course, I look through the slit lamp because I want to check, of course, the cornea integrity. And so if I want to look, I look for some corneal degenerations before doing my examination, my patient examination, or before doing surgery. So yes, I check for symptoms, subjective symptoms. I check for objective data, and I check the most that I can. Of course, anytime I do a therapy and I want to evaluate my patient after therapy. And so, but I think that the osmolarity is very important, especially if you don't have the possibility to check the epithelium or the corneal epithelium, because you may be, I don't know, but you may, I think that you may be very calm, or you have no problem if your patient has normal osmolarity, because you know that the corneal surface usually is healthy in case of normal osmolarity. So I think this is the main or the most important exam that I suggest to do in order to screen your patient, especially in case of anterior segment surgery.
All right, thank you, Dr. Vigo. Dr. GEDAR, do you have any comments on your own experience?
Actually, as an oculoplastic surgeon, I start my examination with eyelids and my bombing glands. The first thing I think I do for my patient is compression of the meibomian glands. If the secretion is good and oily and the ducts are open, actually the other things about dry eye, I think, can solve with the drops or the other medical treatment. But if there is any problem about meibomian glands, we have to solve it with IPL treatment.
All right, and talking about actually expressing glands, I wanted to ask you a question from us. So do you think gland expression, how important do you think it is? Important to say here that with the EI, the protocol says that you do not need to do gland expression to have a complete treatment. The EI treatment alone is sufficient to give you long-term results, as we know. But we know some doctors also like to do gland expression. Dr. GEDAR, and maybe also later Dr. Vigo, do you actually express glands after IPL, and what do you prefer doing?
Sorry, it can be a misunderstanding, the expression of the glands in examination, I mean. When you press the glands, the secretion is, how is the secretion? Is it thick or thin, or the glands are visible or not? I mean the expression, not the not treatment, for examination.
All right. And Dr. Vigo?
There is no need to manually express the glands after the IRPL treatment. Sometimes I do the manual expression, especially if I have some obstructed or very obstructed glands before the treatment. And you know that sometimes I combine different approaches. I mean, also I use the LipiFlow plus the IRPL device in order to get, first of all, the cleaning of the glands, this is obstruction of the glands, and then the stimulation of the glands using the IRPL, the EA device. So it depends, but usually there is no need to manually disobstruct, to squeeze the glands.
All right, thank you, Dr. Vigo. And there's also a poll going on as we speak. You can also all answer if you regularly express any glands after IRPL treatment. And in the meantime, we will also follow up with other questions. We have a question for Dr. Vigo. So Nawar Marcus says that they got a case and the result from a 58-year-old woman who was always had watery eyes. Dr. Luca recommended the IRPL treatment. Will her eyes be less runny? Will she produce less tears? What do you think?
I think that it could be an option, but you have to check if the watery eyes are because there is a compensation of this particular condition that in case of inflammation, chronic inflammation or meibomian gland dysfunction, the patient may have also an increase in producing, in water producing, I mean, in tear film producing, or if there is some like a blepharochalasis or an obstruction in the lacrimal nose duct, and in this case, what we call the epiphora is not well managed using the IRPL, because if the reason of these watery eyes is the meibomian gland dysfunction or the chronic inflammation, yes, you can have very good results using the IRPL. In case of mechanical failure, I mean the obstruction of the lacrimal nose duct, or because the patient has a very important blepharochalasis, especially the inferior blepharochalasis, I think that in this case, maybe that you need also surgery in order to improve your patient's symptoms.
All right, thank you, Dr. VIGO. As well, Dr. GEDAR, do you have any input on this?
I agree to Dr. Luca.
All right. And Dr. GEDAR, actually, we have a question from Sal Jivraj. Do you alter your IRPL treatment for chalazions? And also, do you have any feedback using the tear check?
Okay. I have no experience about tear check. I use only EI device. For the chalazion, if there is only one chalazion, I do operate it. But in Corona times, I don't know why the reason. The patients come us with multiple chalazions and acute blepharitis, acute blepharoconjunctivitis. If the patient has acute phase, I do the first IPL treatment. When the inflammation is suppressed, and I do the surgery after treatment for multiple chalazions and acute blepharitis patients.
All right, thank you. And Dr. VIGO, Dr. GEDAR mentioned more cases of inflammation and chalazions and whatnot in coronavirus times. Are you also seeing this increase?
No, I don't see this increase in terms of chalazion. I think that sometimes you have a patient with multiple chalazion, but I think that in these cases, especially in these cases, there is some systemic issues that is under this kind of disease. And so I suggest the patient also to be visited by an internal, a medical, I mean, a generic medical doctor, I mean, because sometimes it requires also other exams, I mean, systemic exams in order to understand why the patient is suffering from this kind of disease. But usually, yes, I use the pharmacological approach. I mean, I use tetracycline, I use sometimes also steroids, I use warm patches. I use, of course, also the IRPL to help my patients, and sometimes also surgery is needed, but it depends. It depends.
Yes, exactly. And we also have some feedback from Dr. Sal, from Mr. Sal. He's advising that it could also be mask-associated dry eye that could be causing these, although it's maybe too early to imply causation with anything we're lately experiencing, but definitely we can say maybe there should be some sort of association. We have another question as well from Dr. VIGO from Maria Georgiev. Do you have any experience in treatment of dry eye with Casicol eye drops?
Yeah, usually I use classical eye drops. When I screen my dry eye patient, I try always to classify my dry eye patients in meibomian gland dysfunction or lacrimal gland dysfunction, so in excessive evaporation or in hyposecretive dry eye. And usually I try to prescribe, to suggest a specific therapy, I mean also in specific drops that are correlated to different situations. And I usually prescribe artificial tears with fat acid, with liposome inside in case of excessive evaporation, and I prescribe hyaluronic acid or other kind of to hydrate a lot the cornea in case of hyposecretive dry eye. And so, yes, of course, usually I always prescribe also artificial tears, I mean drops, just to help my patient in order to reduce the complaining and to improve the symptoms. Because I think especially at the beginning, it's not enough, or it's not a good idea to suggest only an instrumental approach. I prefer always treat my patient 100%, of course, both by instrumental approach, but also by pharmacological approach. And then the patient himself will decide to stop using drops if the patient will have benefits from the instrumental approach. I mean, for instance, from the IRPL treatment. So usually I start always using the drops and also some other medicines before doing or together with the instrumental approach.
All right, and we have another question, and I guess we can take one more question after that. So a question from Vasco Pinto to both Dr. GEDAR and Dr. VIGO. Why are pacemaker users, diabetic patients and hemophiliac patients a concern? And how does IRPL affect these patients?
Because of the treatment mechanism of the IRPL, the light is absorbed by hemoglobin, you know. It can affect hemophilic pacemaker uses because of they use anti-aggregant therapy, and diabetic patients, they affect the IRPL treatment affect the hemoglobin, and it can cause serious side effects. So it should be careful about these patients.
In my experience, I had never side effects with these specific patients. I had a patient with a pacemaker, and I asked to a colleague of mine that is a cardiologist, and so he told me that I could use this device, and so I did it, and I had no problems as regards the patients that are wearing the pacemakers, and also patients with diabetes. I treated many of them, and I had no problem with all of them. And I have no experience with hemophilic patients because as far as I remember, I don't have this kind of patient, or I mean, I didn't treat this kind of patient. But as regards diabetes or as regards the pacemaker patients, I have no problem at all.
All right, thank you. And our final question from Anya Sever. Is there any clinical research or from your experience regarding better results with using IRPL with patients post-IOL, like multifocals, and their visual fluctuations, and maybe how long does it take to resolve better vision?
I told you that it's better to prevent visual fluctuations. So I think that especially in case of multifocal IOLs, you know that I'm implanting 80% of my cataract patients are multifocal patients. So I implant a lot of multifocal IOLs, and I think that is very important to implant these particular lenses in patients with good tear film before surgery, and not because also you can get wrong data before doing the surgeries, or so you can get wrong refractive results, but especially because patient may have a visual fluctuation after the surgery, and you know that sometimes it's almost normal, especially at the beginning, have some visual fluctuations that can disturb the visual acuity in this specific patient that they want to achieve very beautiful results in terms of distance and near vision. But I think that if you improve the tear film using, for instance, the EI devices before the acquiring the data, and if it is not possible immediately after the surgery or in between the sessions, in between the IRPL session, you can do the surgery. I think that the results are quite good. And so if the patient can have some visual fluctuation, they are not disturbing a lot. And I think that in 1 or 2 months after the surgery, everything disappears and the visual acuity will remain stable. So I think that the timing is not exactly the same for everybody. It depends also on the kind of the tear film that the patient has, but I think that it is effective in restoring tear film and in getting not a stable visual acuity.
Thank you, Dr. Vigo. And with all this, I think we would like to also conclude by also saying to take care in these times with the coronavirus going around and now maybe a rise in cases. Take care of your patients also with the EI as well, the tear check. We'd like to also remind you the tear check is now HT and FDA, HT approved with FDA on the way. And we always hope to bring you the best in dry eye solutions. We would also like to invite you to meet us at the virtual AAO, hoping the time zone would also convene to your own countries, but we would be there presenting at the virtual AAO. And I also would like to thank Dr. GEDAR and Dr. Luca Vigo, and maybe see you all in our next user meeting. Thank you all.
Thank you very much. Thank you very much.
Have a good night.
My pleasure.
Yeah,
All right.
thank you so much. It was a great presentations, and as Lisa said, would be a very great to have a chance to meet in person later, and with all of the audience, and it's a shame that we cannot do this in real, and share information. And but it's what is interesting will teach us, and we talk together with Dr. GEDAR. It's a teach us respect to others, and this is, I think, the great message that we have to respect each other and respect also others in health, in their personal life. And so we really appreciated your effort to be part of our connected family, that we are trying to connect all people with the knowledge and with all your let's say the expertise. Thank you so much again. And I would invite all the audience and others to participate our booth again in virtual one, and also hope that next month to see you and many other faces in our webinar in December, November, December. Yeah. So great. Thank you so much.
Thank you very much. Bye bye.
Bye.
Bye bye.
Ciao.